Hello, and welcome to the 2021 Arch Pro Coatings Online Self-Study Certification Bootcamp, designed to assist you in taking the optional certification exam to earn the credential of a rural health coating and billing specialist, or for those of you in FQHCs or federally qualified health centers, to earn the credential of a community health coding and billing specialist. I am very pleased to offer this as a part of Arch Pro Coatings' overall curriculum, designed to provide information about documentation, coding, and billing specific to rural health clinics and community health. And we'll use the terms community health and FQHC together throughout the course of our journey together. We are based out of Metro Atlanta, but we have instructors and colleagues spread out all across the country, and all we do is support those of you that are operating in health professional shortage areas that face some very unique, especially coding and billing issues, in order to help you drive your revenue and meet your practice's clinical and revenue goals. My name is Gary Lucas. I have been in this industry for a little over 26 years. I've had the opportunity to teach about 1,800 full-day workshops across the country here in 46 states. And so the last 8 to 10 years here has been focused on those of you in rural health, and I'm proud to have joined the team at Arch Pro Coating. You may have formerly known us as the Association for Rural and Community Health Professional Coding, rebranded as Arch Pro Coating, as the ARCH is the Association for Rural and Community Health. You have my contact information down here. I certainly welcome the opportunity to get any feedback from you and or to answer any questions that you may have issues with, whether you take the certification exam or not, as we realize some providers aren't going to be looking for the certification, but are going to value the information related to an understanding of the importance of clinical documentation creation. As many managers, you're not going to necessarily worry about the certification, but we hope that this course will assist you in reaching those goals. We have a couple of disclaimers and disclosures here, of course. In particular, notice the second item, that any CPT codes we mention are owned by both the definitions and the code numbers, and here's the key, and the guidelines written in your CPT manual. They own those definitions, and we'll talk about the limitations of software which do not contain the detailed guidelines printed in the AMA's CPT manual. And we encourage you to make sure, at least prior to our exam, if not prior to continuing in this class, if you do not have an AMA CPT, please grab one, because again, it's the only manual that has these valuable notes. Category 1 CMEs for your clinical providers, or CEUs for those professionals that are earning or maintaining certain credentials, are available following completion of this course according to the requirements that we'll describe as we continue to move forward. So just a confirmation, as I said earlier, about who we help. You have been designated as a rural health clinic. Keep in mind, this is not a doctor's office that happens to be in a rural area. Rather, you've been credentialed and certified and approved as a designated rural health clinic. And as we advance deeper into this class, you'll notice that we'll talk about the differences in two categories of rural health clinics, namely what's called an independent rural health clinic that might have some different billing rules than one that's referred to as provider-based. So we'll elaborate on that as we continue here shortly, but also federally qualified health centers. But the reason we're going to use the terms, community health, is you don't have FQHC probably printed on your sign or, in your materials. Rather, your facility is named, ABC Primary Care Center or Community Health Center. But do note that community health centers can occur in either a rural or urban health professional shortage area. And again, you have some different requirements that are unique to community health centers, just like rural health clinics have. And as you notice on the bottom of the screen there, the name of the credentials that many of you may be looking to earn. Now, these aren't the only two facilities that are operating in health professional shortage areas. There are also critical access hospitals, known as CAHs, and small rural, what are called PPS hospitals. And depending upon if you're a critical access hospital, there are some very unique issues as to whether you're billing based on what's called Method 1 or Method 2 billing, or you're one of those PPS hospitals. Now, this class is designed for the first two categories, but our colleague and my dear friend Jackie King also teaches and has a live and an online self-study version for those of you interested in critical access hospitals. Now, many of you may be taking this class working in a hospital because you may now own, or you've purchased, or you've set up outside offices as a rural health clinic, and you've noticed that a lot of the rules for them are very different than your traditional Medicare Part B facility, and you've seen some complexities. So we hope those of you that are in hospitals reporting services for provider-based rural health clinics find significant value here and opportunities for reimbursement. Our target audience is really broad. We don't just want to talk to coders and billers and quality reporting staff and so forth. We really need the active involvement of our clinical providers, whose primary role, obviously, to provide the clinical care at the highest levels, based on your state's guidelines. But as it relates to our course, their job, as we are going to focus on, is to document 100% of what was done. As you notice, that's with your CPT and or your HCPCS Level 2 codes, and why those services were performed based on the ICD-10 CM codes. And the key there is per the official guidelines. Again, there's a lot of information tucked into these manuals that you won't see if you're using software as a substitute. But our goal here is for clinical providers to be able to effectuate the optimal level of care, but to document it according to the guidelines for a variety of purposes that goes beyond reimbursement, whether it's liability or malpractice protections, whether it's medical necessity, or creating full and complete and timely notes for coordination of care when other providers are going to be looking at the service either through the documentation or an eventual listing of all the codes as we move across the screen. So clearly we have clinical providers responsible for the documentation piece, but I'm going to put facility leadership as being primarily responsible for coding, okay? So even though we know facility leadership is not going to be involved in this on a day-to-day basis, many managers came up through the front desk or came from another facility and may not be aware of a lot of the nuances of what we're going to be talking about throughout this course. So clearly, it's the billing staff and or the coders that are going to be reporting the services on different claim forms to different insurance company that use different billing rules to pay us with different methodologies. For example, fee for service versus our encounter rates that we get for Medicare versus maybe per member per month claims where we get a specific amount of money from each patient, related to each patient, that can actually go up or down based on diagnosis codes. So the job and the role of facility leadership in this course is to become familiar with the guidelines and potential risks and or issues and opportunities that the clinical providers are going to face and that the billers are going to face through effective creation of policies and procedures and effective workflows that use our enabling technologies like EHRs and billing systems in order to capture 100% of what we do on that encounter form, or you may refer to it as a super bill. Now, keep in mind that we don't code each service just to get paid. There are many things we do in rural health and community health that are not directly reimbursable today, but based on something we'll discuss later called a cost report, an annual cost report being a required element that these facilities need to submit every year to both Medicare and Medicaid in order to determine our true costs. All right. So we'll get into details such as Medicare doesn't want us to report a 99211 nurse visit if they didn't see an authorized provider today, but we still have to document it. We still code it. We still need to make sure it goes into our systems even though we don't get paid for it today, so that in that cost report, we can show a true reflection of our costs based on what we've done, not just what we got paid for. Of course, on the far right side there, you see getting paid 100% of what you should, but no more than is allowed by understanding the differing payer rules. And that's kind of the tricky wicket right there. And for those of you that aren't as experienced in billing and coding, let me go back here to the slide there. Notice at the bottom, we have more control internally over the performance of our providers based on how they're documenting, and it's more difficult. And we have less control internally over getting paid correctly. But again, managers, you're the ones dealing with folks on both sides, and we welcome CFOs and front desk managers and revenue cycle managers who aren't documenting in the record and aren't sending the bills, but through this type of knowledge and building a shared platform of knowledge across each of these target groups, we will be presenting information to all three of you in each section. Although, for example, in the documentation section, yes, the focus will be on providers, etc. So some possible challenges and issues that you may be currently facing, or for those of you looking to open an FQHC or open a rural health clinic, we anticipate, just like your friends that work at traditional doctor's offices, that some of your providers may be understandably frustrated with the impact and just pure amount of documentation rules that some providers feel impedes their ability to treat their patients. Rather, they have to focus on the codes and the documentation. So we acknowledge that, and we'll identify significant benefits of this course by reducing that frustration to the providers. But another possible challenge and issue, let's be honest, is that your providers may not have ever seen some of the guidelines that are in this CPT. They may not be able to locate some of the important notes that appear above a lot of diagnosis codes. Rather, they might just be doing some keyword lookups to find those codes without seeing the full guidelines. So they may be dependent on too many IT and EHR shortcuts, whereas we together in this course are going to identify where the rules are and help you build shortcuts, but doing so based on the actual guidelines themselves. So you see the symbol there that you might locate across this presentation for clinical providers. It's going to have the bright light bulb. Of course, they are brilliant in order to become a PA and an NP and a doc, etc. But it may be a lack of education on the key areas that lead to that understandable frustration. Next, managers, you may have an understandable difficulty keeping track of the true impact that each of the commercial insurance contracts we sign bring us. Different Medicaid programs cover different services that might differ from Medicare, that might differ from your straight ahead insurance companies, let alone workers' comp, etc. And even if your patient is self-pay, even if they do not have a dollar to their name, we obviously document the same and treat that patient the same. Therefore, the coding is going to be the same for all patients, irrespective of their insurance type or ability to pay. They still deserve to get a full listing of everything that was done and why, whether they pay the bill or not. You could have somebody coming in with money dropping out of their pockets. They also have the same right, if you will, and we have the same need to capture what was done and to code it in order to determine what they may be responsible for, or whether or not we might be able to give them some financial assistance through an approved an authorized sliding fee scale, etc. So the challenge for management is really determining who is responsible for coding. A lot of us have our providers perform the documentation. We have them complete a super bill or an encounter form that in years past was on a piece of paper, but is likely moved recently to an electronic format by which the providers give information to billing about what was done and why. But that tends to happen in most facilities before the documentation is actually completed by your provider. So in my opinion, the coding responsibilities goes first to management by driving teamwork between the providers and the coders and billers, because sometimes it's difficult to do that when your EHR or IT systems don't talk well to each other. You have to build manual workarounds. So, we realize again that managers aren't doing the coding, but they have to manage the process to make sure it's done effectively. The troubles and issues and common issues I've heard over, again, close to 2,000 courses like this, is that it's difficulty to balance the different needs on claim forms when we're getting paid fee for service versus our daily encounter rates, what many of you may call your per diem amounts when you're billing Medicare and maybe some Medicaid programs. Your challenge in this issue is you knew slam dunk how to get paid when you worked in a traditional doctor's office that wasn't an RHC, was not in a health professional shortage area. But it's difficult to find information specific to our focus and entirely our company's goals of just serving those of you who take care of America's underserved health population. And so that's what we're here for today. There are other great certification and training programs out there, but unfortunately they require you to learn this whole book when you're not going to be doing major surgeries and radiation oncology and anesthesia, etc., at your office. Additionally, a lot of folks report to me that if they try to go to a provider to ask a question, when that person's walking with their ICD-10 book and they see the provider in the hallway and they have a question about maybe a different diagnosis code, as soon as that provider sees them walking down the hallway, boy, they sure take off sometimes. So again, managers, we need to be able to find a good way to develop routine communications between your documentation folks and your billing and quality folks. So as we continue here, let's confirm the benefits we hope you gain out of this, and at the end, we will hopefully identify that we achieved these goals. And by giving you my contact information, if you encounter unique issues, unique to your facility, I welcome the opportunity to provide assistance for you. So, an increased focus on the importance of accurate and complete and timely notes for the providers will help enhance coordination of care, not only with providers in your facility. For example, maybe you have a patient with substance abuse or opioid use disorders, and you have to be very careful of having medical notes done by medical providers for, let's say, medication-assisted treatment, while you have concurrent behavioral health or mental health services being provided that might actually use a different medical record in order to confirm how care is going. So we benefit internal and external coordination of care with providers at other facilities and even at hospitals, etc. We also want you to get proper credit for the work that you do. If you have one provider that is doing pure coding on the super bill versus the other provider who's doing billing, they're actually going beyond documenting. They're going beyond coding. They say, I may not get paid for both of these services, so I'm only going to put one of them on the encounter form. Well, you're not getting credit for the work that you're doing. We hope that this will allow a proper identification not only of your facility's role in documenting and code capture, but helping you get the credit if you have a physician or a provider compensation plan that's based on what you've done. Now, obviously in 2021, during the current public health emergency, the providing public health, let alone the insurance companies, with accurate diagnosis codes that reflect what was done today Not necessarily every diagnosis they have, but by putting those codes in the proper order will benefit public health because, folks, they are using the information you submit on every claim to make important local, state, and federal health decisions, not just related to the public health emergency, but to track and monitor the incidences of diabetes and heart failure and all those other things that are out there. So they're really dependent on our documentation and coding. The benefit of this course will allow your facility to report its true costs on that annual cost report, because in the past, what I've seen off the record is that some facilities in the past would say, you know what, let's just put a 99213 down, whether it was a level 4 visit or a level 5 visit, whether we also did a joint injection using Synvisc or Hyaluronic or whatever. We're going to get paid the same from Medicare, so we only put that one code on there. Well, folks, if we didn't capture that information that was documented in the record, it won't be shown on our cost report, and that will discourage or bring our potential daily rates down when our actual costs may be going up. So in order to manage compensation plans and maximize revenue, that true coordination of the manager sitting in the middle will be very important. Now, turnover is high in rural and community health. So this obviously doesn't just benefit those billers, but it benefits the facility at whole by giving somebody the recognition and credentialing that is most reflective of what they do on a daily basis. There are other coding certifications out there, but they don't have any questions about billing. There are some medical billing new certifications out there, but they don't include details on rural and community health. So we hope this provides that individual with the ability to help not only meet the facility's financial goals, but their own, to show their certification and help have a career in healthcare, not just a job. And so the idea down there of learn more to earn more applies over the entire course. And so you see at the bottom now, team-based training can build a shared foundation of knowledge. Although we realize you may share a couple of pieces of this video to folks who weren't signed up, please realize that only those that signed up are eligible for CEUs and or the opportunity to take the full exam. All right, so let's estimate, and this is a little different when we're teaching in person, so I appreciate the opportunity that you may need to take to pause and go ask questions of folks in your facility, but estimate your performance in these areas, and throughout the course, let's talk about how we're going to develop plans to improve where's needed, and please know, if you've already printed your slides out in grayscale so that it's not too dark to see as opposed to black and white. There are at the end of this class a set of maybe 4 or 5 slides that outline the action items that pull from the entire course and put them on a couple 4 or 5 slides to help those of you make plans where needed. But ask yourself these questions. Does your clinical and revenue cycle staff have a shared foundation of knowledge on documentation, coding, and billing that fits your clinical and business needs? Are your clinical providers of where they can locate the documentation guidelines that are found in those coding manuals? Who is truly responsible for coding? And are we fully coding each encounter, not based on billing rules, but based on the guidelines in the CPT book and in the HCPCS Level 2 code book and or your diagnosis code book? That is one of the most important core concepts in this entire course, that sometimes there's a hole there. Provider documents indicates the codes on the encounter form. The note's not completed yet. Billing is highly encouraged to get that claim out of the door, possibly before the note's even completed. And nobody might go back and confirm that the codes we put in our billing system are supported by documentation. Or did the provider finish their documentation, a day or two after billing put the codes in, and did somebody in billing notice before the claim went out, hey, wait a minute, they also documented removal of impacted earwax or removal of impacted cerumen requiring instrumentation that they maybe didn't realize should have gone on the encounter form? Did somebody catch that before the bill went out to maybe generate more revenue, especially to those payers paying us fee for service? So that is part and parcel with, if these are low, if this is still a question, the ultimate goal related to our revenue is going to be very difficult to achieve. So we're not just going to focus on negatives, folks. We'll focus on a lot of the positives, but I hope this puts many of you into a kind of a same bucket so we can share our goals of providing the best clinical care possible, letting everybody know what our true costs are, and by getting paid what we need to be able to stay open, viable, and successful. So the path that we all share is going to be mirrored in the organization of this class. Gonna need to get some drinks here every now and then. So what we're going to do is we're going to start by discussing in the next section, what do we need to do to truly be ready to see the patient? I mean, before we open our door the first time, or hey, we're working, but we institute a lot of these items found in the training course. What do we need to truly be ready to open our doors to handle the advanced issues of operating in a rural health or community health center? And I'll tell you right now, my first 18, 19 years in this industry was focused on fee-for-service offices. You'd bill on a 1,500 claim form, you'd bill fee for service, you knew what the global surgical package rules were, you knew where to locate it, and boom, all of a sudden, you start getting paid per diem or daily rates, or what we're going to call encounter rates for Medicare, but we're reporting it on a different claim form that's usually associated with facilities and hospitals. And you were the greatest coder and biller of all time, but nobody ever told you the difference in the guidelines for submitting encounter-based payments on a 1450 form, or what you might call that UB form. So we're going to truly hit some issues that show that, in my firm opinion, the billing in rural health and community health is more difficult than in a traditional office. So now we've opened our doors, we've prepared, we understand our insurance contracts, we have access to the manuals, we've outlined the differences in how we operate to some insurance companies as a rural health clinic or a community health center. And all of a sudden, we now have to operate differently when some medical insurance companies see us as just a traditional doctor's office. So that's a pretty tough balance we will strike through and work through together. Now, we greet the patient. What does our front desk need to know about clarifying the coinsurance requirements to providers, letting them know what the general benefits are of their insurance plans and how it may differ from Medicare to Medicaid to managed care, etc. What claim forms are we using? What patient cost sharing's out there? Deductibles are different, by the way, for rural health clinics. Coinsurance amounts are different. And so we'll talk about how we can utilize our front desk by being educated on the outline of our scope here to help identify to the patients, hey, I know you're here for a preventive visit, but is there anything else that you're having problems with we need to let the providers know about up front? So in summary, the front desk's knowledge and awareness of the documentation, coding, and billing rules affects far more than just revenue. It affects patient room management, provider satisfaction and capabilities to complete their documentation by understanding what the visit will truly entail, as well as the impacts on coding and billing. As we move next, that patient is in the exam room, that door is shut, and that nurse, PA, NP, MD, etc. is in that room providing the care that requires detailed knowledge of the actual guidelines found in the CPT. Our clear primary focus in this area will be on evaluation and management codes, whether it's a sick visit or a problem-oriented visit, or if it's a preventive medicine service. If it's a preventive medicine service, is it coming from the CPTs, preventive medicine service codes, or are we actually providing one of those, quote, sometimes covered G codes for a Medicare patient where there are specific covered preventive services reported at an annual or biannual basis And there's a nice list at the very end of this class in the billing section that's going to outline all of those for you. Here in the treat and document the visit, we'll outline the general concepts of preventive visits versus sick visits. We'll talk care management services, virtual communication services, telemedicine, etc., as we transition to the code the full encounter. Managing those links between completed documentation and the encounter form. And if any of those areas break down, or if this item does not occur, then we're not going to be able to achieve the goals in the last section of confirming the documentation, making sure that before that claim goes out, that the note is complete and accurate and timely and dated and authenticated, etc. And that's the area that often gets lost. And this may end up requiring you to hire a coder or a biller, etc. But you will get that revenue back through a more clear capture of the documentation, of the full codes that are performed. And if that provider happened to not indicate that they did an impacted earwax removal requiring instrumentation, as we mentioned, we're going to catch that before we send the bill out. And so managing those links and really focusing on this area where the star is will be a primary focus of ours. So please don't expect us, we're not going to have just 5 videos here. We're going to break each video into, let's just call it about 45-minute chunks. And especially in the treat and document and code the encounters fully area, we're going to ask you occasionally to stop the video, to use the functions of the learning management system to access some quizzes that will allow you to get some hands-on practice in the CPT. For example, if we're coding the excision of a benign lesion, did we also code or document the margins around that lesion? Are we allowed to, or when are we allowed to, additionally report the repair of the defect that's left when we excise that lesion? So we'll give you the chance to go in and code and document and do quizzes on trigger point injections and procedures. So our focus is on E&M in those 2 sections, the treat and document and code the encounter, but we're also going to give you hands-on practice for procedures. And I'll tell you right now that it's the accurate coding of procedures that has the best potential for increasing your revenue, not necessarily to Medicare, but you better believe it, to those commercial insurance companies that pay you fee for service that use different rules than Medicare of when a visit and a procedure can be reported together. So, as you work through this section, we will continue to focus on the goals for the providers of documenting 100% of what was done, whether it's payable or not, following the guidelines, extracting 100% of the codes from the encounter based on the guidelines that don't really change between the different insurance types. Obviously to the goal of generating 100% of the revenue you're entitled to, but no more, by even going back and showing your carriers and showing your payers why they should have paid a claim, not by necessarily saying this guy Gary through the class, as I said in many classes, told this to me on slide 56. Rather, go to section 40.4 of the claims manual and notice that ABC. And we'll give you those references and the ability to print manual sections from Medicare, national coverage decisions, and Medicare fact sheets about RHCs and FQHCs, etc. And if you're not sure where you fall on the spectrum of beginner to intermediate to advanced, this should hopefully give you a little bit of an arbiter of where you stand following class after you review your notes and the slide notes that you made if you printed them out. And again, we do encourage you to print the slides out in grayscale, not in black and white, so that you can make a lot of notes. You're going to see me highlight on the screen quite often. Take those hints and those suggestions very carefully, because we write the exams, and I am the kind of the final gatekeeper, if you will, of the exam questions. So We're going to give you hints on what you need to look for. So maybe you have a limited awareness of where the guidelines are, or you are doing just basic data entry of codes from the encounter form into your claim system. You're not sending claims to insurance companies, but you're really not aware, understandably, of the unique differences between how different payers want you to bill. And it is correct to state that you are going to be billing different patients differently based on the terms of their insurance contracts and charging different co-insurance amounts than you're used to. And so the concept of documentation doesn't change based on the patient's insurance or ability to pay. Therefore, the coding should not change, but you better believe the billing will. You're probably in the intermediate area if you're performing management functions. You're managing people, or you're managing the EHR or the billing systems or whatever, but you might need to be updating or enforcing policies, hopefully related to recent changes, not just the way things have always been. You might have a limited ability to look at medical documentation and turn it into the proper codes. We hope to increase that for everybody, but those managers, you're likely the one who is signing that contract, if not your CEO, etc. You're the one signing the contract that says we will abide by potentially differing rules than we deal with other insurance companies. So you're ready to take the exam after class, after studying following class, after taking our included practice exam that will open up after you complete all of the videos. We can't fast forward the videos. You are going to have to run these through to completion to likely open up the next sections. But you're ready for the exam. You're ready for the advanced area to earn that certification. If you can locate those national and local coverage decisions that Medicare puts out, and you can train others on how coding and billing are different, please feel free to utilize the slides in this presentation to train your colleagues and providers that aren't having to listen to me for many, many hours. But again, the CEUs and the optional certification exam and the practice exam are only available to registered attendees. But you are ready if you can review documentation, assign codes based on those guidelines, and then adjust the claims to meet those varying payer needs and the ability to appeal denied claims by educating your insurance companies on the guidelines. And we'll give you a lot of examples there. So as we prepare to go to the next section, we've completed the bootcamp introduction. We're ready to move into the prepare to see the patients. Notice the next two chapters kind of lean towards building you up from that area of a beginner towards intermediate. And those two chapters, the prepare and greet chapters, are going to be both rural health and community health. So your exams are different. Your billing piece of your examinations for the certification exam will be different based on if you're a FQHC or rural health clinic. But there's information in these first two chapters that we need to know, not only for our facility, but the other facility type in case you move from working in a rural health clinic to a community health center, etc. So there are some foundational issues that will require you to compare and contrast both rural health and community health. But again, on your exams, we'll point out by the time we get to that section, the importance of being careful if you're being asked a documentation question that should be consistent across all facility types. Are we asking you a coding question, which should be pretty consistent across all payer types, versus when we get to the bill that will definitely be different. So when you return here, we will be ready to go into the next chapter. Be prepared to follow any instructions that pop up once the video is completed for any quizzes or polls or evaluations. And we look forward to seeing you in the next chapter, preparing to see your patients. Thank you so much. We'll see you in the next chapter.